All right, good afternoon, everyone. Thank you very much for coming. So we're going to do a lecture today on the use of coronary CTA for TAVR and TAVI planning. All right. So today's topic is on aortic stenosis and how to use CTA for pre-procedural planning for TAVR. So a few words on aortic stenosis. As you all know, it's most frequently caused by age-related valvular calcification, less likely to be caused by rheumatic heart disease nowadays. Aortic valve, you know, is commonly tri-leaflet but can also be bicuspid. It's a disease commonly seen in older individuals, but younger people with bicuspid can certainly have severe AS. And as you all know, echocardiography is still the primary modality for diagnosing AS. And so the way we diagnose it is, as you know, based on gradients. So we estimate the peak velocity, the mean gradient, and then from the LVOT measurements, we derive an aortic valve area, which is an estimated based on the continuity equation. And based on those numbers, as you all know very well, we can grade aortic stenosis as mild, moderate to severe. Severe being a gradient more than 40, peak velocity more than 4, and an aortic valve area less than 1. Now, the management of aortic stenosis has evolved over the years. From the latest 2020 guidelines, you can see very clearly that management of severe AS without symptoms, it can either be done with TAVR or TAVR. So you can really go one way or another. Of course, it's a heart-based team approach, so there's a lot of patient-related factors that come into play, but you can certainly do TAVR or TAVR. Now, TAVR valves or surgical aortic valve replacement can be either from using mechanical valves or bioprosthetics. You have this bi-leaflet tilting disc, or you can have one disc, or you can have a cage and ball, which we don't really see these days. Bioprosthetic valves can be stented or stentless. And then the topic of our discussion today is TAVR valves, transcatheter bioprosthetic valves. TAVR has been a rapidly evolving field ever since the first valve was implanted way back in 2002, which is crazy. It's like 22 years ago. The first TAVR was approved in inoperable patients, and then slowly it went from high risk to intermediate risk and then to low risk patients recently. And the success of TAVR has improved with operator experience. So people have been doing this for a while, are very adept at doing it. Device technology has improved. And then more importantly, patient selection and pre-procedural planning has also evolved, especially with the use of CTA. This is the first TAVR that was ever performed back in 2002 by Dr. Alain Cribier. He performed the first successful percutaneous TAVR, and this was on an inoperable patient who could not get aortic valve replacement surgically. So as you can see, the TAVR selection for patients started from inoperable patients with the first partner trials in 2010. So it gained FDA approval for prohibitive risk patients, and this compared TAVR to basically medical management. And then the partner trials, core valve high-risk trials, examined TAVR versus TAVR in high-risk patients. And then you had your intermediate risk patients in 2016, 2017. And then in 2015, the first TAVR was approved for valve-in-valve. And then more recently, just a couple of years ago, the partner trials, Evolute low-risk trials, led to FDA approval for TAVR to be used in low-risk patients. So it's a very tremendously successful story with how TAVR evolved from first inoperable patients and now just to low-risk patients. TAVR valves are two main kinds of valves. You have your self-expandable valves, which are placed supraannular, so the leaflets open above the annulus. And then you have your balloon expandable valves, which are where the leaflets are at the annulus. I'll show you a picture. So these are the two main components of TAVR valves. So your balloon expandable valve here, you can see you have your metallic frame, and then you have a skirt that kind of surrounds the frame. Same thing for your supraannular self-expanding valve. You can see the metallic frame here with the skirt. And you can see that the leaflets here, how they open in systole and they close in diastole, as you would expect them to. So same thing here, systole and diastole. And your self-expanding valves, you can see, are placed supraannular. So here's the metallic frame, and you can see the leaflets here, they open above the annulus being somewhere here. And then your balloon expandable valves, the leaflets are placed at the annular level. So here's the metallic frame, and here are the leaflets at the annulus. So the topic of my presentation today is how to use CTA for pre-procedural planning for TAVR. So here's the outline of my presentation. We'll start with what CTA data acquisition we use and the reconstruction that we use to do all these measurements. We evaluate the aortic valve root, the aortic valve itself, the annulus, and the aorta. We assess coronary ostial heights. We look for vascular access. You can assess the coronary arteries. And lastly, we always, because the imaging plane goes all the way from the thyroid almost down to the pelvis, a lot of organs there that we can assess, so we can always look for non-cardiac findings. So the first step in any CT data acquisition is to do just a regular non-contrast CT of the aortic valve. And there we're looking for aortic valve calcification. And we use the same scan parameters as we do for coronary artery calcium score, where we use a tube potential of 120 kV, slice thickness of 3 millimeter. And we measure how much calcification there is around the aortic valve. And we grade it based on the Agatston scoring technique, just like we do with coronary arteries. We have to be very careful when we're doing these measurements that we're circling only the calcification in the aortic valve. So we don't want to include aortic root calcification. We don't want to include coronary calcification, like in the left main or the right coronary ostium. And then you don't want to include mitral annular calcification. If you include those, you can overly estimate how much calcification you have around the aortic valve. And so aortic valve calcium can be especially useful, as you know, in patients with low flow, low gradient, and those with preserved or reduced EF. As you know, an Agatston score more than 3,000 in men or 1,600 in women makes the diagnosis of severe AS more likely, whereas a score less than those thresholds makes it less likely. So the first step is always to do a non-contrast just for aortic valve calcification. So here's a non-contrast CT, where you can see that here's some aortic root calcification, here's calcification around the left main. So you want to include only the aortic valve calcification. So you just draw a region of interest, and then the software basically just calculates the aortic valve calcium score. Now the CTA data acquisition part, there's two parts to it. So one is a retrospective data acquisition that covers at least the aortic root. So you do arch to apex, just heart only essentially. And it's retrospective, so tube is on for the entire cardiac cycle from 0% RR all the way to 95%. And then when we reconstruct either in 5% increment or 50 millisecond increments. And this is important to do retrospective. We can't just do prospective of the annulus, because you want to make sure that you're getting the annulus measurements in systole, and you want to make sure that you get the largest systolic measurements. As you know, the aortic annulus dimensions are usually larger in systole than diastole, with some exceptions that we'll refer to in a couple of slides. And then for aortic valve area by planimetry, you always want to make sure that you measure the widest opening during systole, and you measure at the leaflet tips. And I'll give you some examples. Because we're imaging the heart, we can look at the coronary arteries. So we're looking at all the phases of the cardiac cycle. So you can assess the coronaries, keeping in mind that you want to make sure you select the phase with the least amount of motion. Coronary heights are assessed in diastole. Aortic regurgitation can also be assessed because we're covering the entire cardiac cycle, so systole for stenosis, diastole for regurgitation. And because we're covering the entire cardiac cycle, we can assess LVEF and right ventricular ejection fraction. So you have a wealth of information from that CTA, and it's EKG synchronized, right? We want to make sure that we're gating everything to EKG. So after this retrospective scan of the heart only, we do a non-EKG synchronized data acquisition that starts all the way from the top for the carotids, that goes all the way down to the iliac arteries. And there, why we're doing so is because we want to get all the aorta, so from the ascending all the way down to the abdominal and the iliac arteries. So you can look for aortic dimensions, you can assess the access vessels, including the iliacs, the femorals, and the carotids in some cases. And then because we have so many organs that are covered by that scan range, you can look for non-cardiac findings as well. That may be very relevant. So whenever we scan a patient, yes, the number one thing is that we want to make sure that we get an adequate image, but we want to try to minimize radiation whenever we can. So for patients weighing less than 90 kilograms or a BMI less than 30, you can choose a tube potential of 100 kV. That will still give you adequate images. But patients who weigh more than 90 kilograms or BMI more than 30, we should probably do a tube potential at least of 120. One way to minimize radiation during the retrospective scan of the heart is we can do tube modulation. So you can lower the tube KV during systole. That's where most of the amount of motion happens in the coronaries. And then you can go back in diastole. So you can do some tube modulation. That can lower your KV, your radiation dose by about 30–50%. IV hydration before the scan can be helpful in patients with severe renal impairment. Beta blockers should be used judiciously. As you know, severe AS, beta blockers should be used very cautiously because you don't want to decompensate them. And nitrates, of course, are contraindicated, right? So as you know, when we're doing CTA for coronary arteries, commonly we will always give nitrates, right, to open up the coronaries. So assessment of coronary arteries in TAVR cases can be a little bit difficult because we're not giving nitrates or beta blockers. So a few words on the aortic valve anatomy. The aortic annulus, as you know, is basically the basal insertion point of all three aortic leaflets. Aortic valve is tricuspid, so you have your left coronary cusp, your non, and your right. And so there's an imaginary plane here that encompasses all the basal insertion point of the three leaflets. And that plane is basically called your annulus. It's not a real structure, it's a virtual ring, basically, formed by joining the basal attachments of the aortic valve leaflets. Now, the top of the leaflets is basically your sinotubular junction. And then above that is your aorta. So when we do your measurements for the aortic annulus, you want to make sure that you identify the lowest attachment of all three leaflets. And we're going to go over that in great detail. So for the aortic annulus, as you know, in systole, there are conformational changes that happen, which result in decrease in ellipticity and stretch of the annular contour. That will usually result in a larger annular dimensions in systole as compared to diastole. That's what's referred to as annular dynamism. So the reader should identify the reconstruction phase with the largest annular dimensions, and that's somewhere in systole, right? So 25 to 40%, somewhere about, you should be looking for those dimensions in those phases. So you want to make sure that you identify a reconstruction phase with adequate image quality. So you want to make sure that there's no motion in the annulus, because you want to make sure that those measurements are accurate. So no motion artifacts, no double contours, or step stair artifacts. If any of those artifacts happen, you can always go back and edit. So if there's any extra beats, like AFib, PVCs, PAC, the text can always go back and edit those extra beats out so we can get more sharp contours. Because we want to make sure that we're measuring that annulus as accurately as we can. Because as you know, the sizing of TAVR valves is based on annulus. So I pulled this slide from the SCCT guidelines on TAVR on how to identify the annular ring. So as you know, in CT, you get your axial images, and then your coronal and your sagittal. So you always want to do a double oblique at the coronal and the sagittal. So you get double oblique here, double oblique here. So you get double oblique at the axial. So you move your cursor down in the axial images till you identify the lowest insertion point of the right coronary cusp. See that? So those two structures here, that's the annulus at the left coronary cusp and the non-coronary cusp. So first you identify the lowest insertion point of the right coronary cusp, and then you place your cursor here, right there, at the RCC. Next, keeping your cursor here, you move counterclockwise till you get the NCC lowest dimension here. And then at the coronal, basically that coronal plane, you get the basically your RCC and your NCC. And then you move your you move your coronal plane up and down until you identify the lowest insertion point of the non-coronary cusp. Once you do so, your coronal plane will have your lowest insertion point for the RCC and the NCC. That's the RCC here, and that's the NCC. So once you have identified the RCC and the NCC, then you go to your sagittal plane, and then you identify the lowest insertion point of the LCC, the left coronary cusp. So basically, you move your red line here up and down until you identify the lowest point here. So in your axial plane now, you have the lowest insertion point of all three coronary leaflets, right coronary cusp, non-coronary cusp, and your left coronary cusp. And remember, that's your anatomy, right? The annulus is a virtual ring formed by the basal insertion point of all three leaflets. Once you identify the lowest insertion point of all three leaflets, then you can do your measurements. So using a spline contour, you just mark the edges of the annulus, and then you measure your widest dimension and your perpendicular dimension. And then you report your perimeter, your area, and these two dimensions. Now there are multiple ways how to measure the annulus. You can have a freehand contour tool. So in whatever software you're using, there are three ways usually you can do these contours. The freehand contour is really not a recommended way to do the annulus measurements because it can lead to overestimation of the perimeter because you're not using a smoothened contour. Polygonal is another way to do it. You just place a number of dots, and then and this may be actually a closer estimate of the annulus as compared to freehand. But really what the guideline recommends is using a spline contour. So you just keep moving your spline, keep putting dots around, and then it just uses the spline method to smooth the edges. And then that usually yields the most accurate quantification of the annular perimeter. So always use spline contour. A few words about, again, annular dynamism. See here systole and diastole. So commonly your aortic annulus is larger in systole. There's these conformational changes, and the annulus is a little bit more elliptical in systole compared to diastole. So that's why you want to make sure that you measure your annulus in systole. There's one exception in septal hypertrophies like Holcomb patients where actually your annulus dimensions are smaller in systole compared to diastole. So see here it's systole versus diastole. So it's only in that exception where you do your annular measurements in diastole. Balloon expandable devices are largely based on annular area, whereas self-expandable devices are based on perimeter. But whenever we report these annular measurements, we give both the area and the perimeter so that whatever device they end up picking, they can base it off the perimeter or area. A few words on landing zone calcium. So we know that TAVR valves are either inserted in the native aortic valve, which is more commonly very heavily calcified. So that those calcification of the valve and the annulus can be like the landing zone for TAVR. So you have to be very careful when you're reporting this calcification because yes, you do want these anchorage points for your TAVR, but then a lot of calcification in the annulus can lead to annular rupture and can lead to perivalvular leaks. So we'll give you some examples on that. So severe calcification of the LVOT and the aortic valve is associated with an increased risk of perivalvular regurgitation, especially when that calcium protrudes inside the LVOT. And so that's another reason why we do the aortic valve areas. We want to give an idea of how much calcification there is. And then large protruding nodules of calcification may increase the risk of annular rupture, especially when you're using balloon expandable valves. And then annular and subannular calcification, especially when it protrudes again in the lumen, can result in increased risk of both annular rupture and perivalvular leak. And most commonly, protruding landing zone calcification, specifically below the non-coronary cusp, has been shown to be most closely associated with annular injury. And this effect is amplified when you're using aggressive balloon expanding for annular oversizing. So here's a aortic valve calcification. I just chose a coronal view so you can appreciate the different calcification that we see. So here's aortic root calcification, and then your aortic valve calcification is somewhere here, and then all this below the annulus is subannular calcification. This is very important to report on because it can have implications for injury when you're deploying the TAVR valve. So here's how you grade aortic annular calcification. It can be either mild. You see the single adherent non-protruding focus. See this calcification here is not really protruding inside the LVOT. And one word, when you're doing annular measurements, what the guidelines say is that when you're including this calcium, you don't want to include all of the calcium here. You just imagine it as if there's no calcium, and you just bisect the calcium so that you're doing the measurements here. Otherwise, you're going to overestimate your annular perimeter and area. Moderate is when you have one or more nodules, or two or more nodules, with limited protrusion inside the LVOT. So here's a big nodule and a smaller nodule here. And you can see it's starting to protrude inside the annulus. And then severe is when you have single or multiple nodules of calcification that are clearly protruding inside the LVOT. See, from this coronal view, all this calcium is mostly below the non-coronary cusp and is protruding into the annulus. So it's very important when you're reporting on a TAVR report that you mention these nodules of calcification and grade them based on mild, moderate, or severe. Coronary ostial heights are very important to report because low coronary ostial heights, usually less than 12 millimeter from the annulus, carry with it an increased risk of coronary occlusion. Again, I pulled this slide from the SCCT guideline on how to report coronary ostial heights. So again, as we did for annular measurements, you do double oblique in diastole this time, not systole. And you identify all three basal insertion points of the aortic valve cusps. So you get this double oblique view. And then from this view, keep your cursor there. You can move up and down the coronal and sagittal planes so that you don't want to move up and down the axial plane, because once you identified your plane in the axial view, you want to keep it locked there and just move up and down the coronal and sagittal till you identify the left coronary ostium. From there, you draw a horizontal line and you measure the distance from the ostium to that horizontal line, and that's basically your left coronary height. And then you do the same for your right ostium. Right coronary ostium, you draw a perpendicular line to the annulus, and then you measure your right coronary height. The aortic root measurements commonly are done in diastole, and similarly, you want to report a double oblique view. So you do oblique in the coronal, oblique in the sagittal, so that when you get to your axial, it's a double oblique view. You have your three cusps here, the right cusp, the non-cusp, and the left coronary cusp. Whenever you report your aortic root dimensions, you want to make sure that you report the largest dimension. So you do all three measurements, right to non, left to non, and then right to non. And then if they're all the same, you can just report the average. If they're different, you want to report the largest dimension. Most commonly, we do left coronary to non-coronary cusp. If all three cusps are similarly, are equidistant, essentially. After the aortic root comes the sinotubular junction. So you just move your cursor just up in the axial plane till you get a double oblique view in the coronal and sagittal, and then you report your sinotubular junction. So same thing, you draw two measurements and then you report the largest measurement. So all the measurements, I want to make sure that I stress this, that all the measurements of the aortic root, aorta, access vessels are done double oblique. You can either do this with the help of software, that the software will do double oblique for you, or you do it manually and just do a double oblique yourself. But always make sure you do double oblique measurements. After the sinotubular junction, you report on the mid-ascending thoracic aorta. So again, double oblique. You report this measurement. You, for the aortic valve morphology, whether it's tri-leaflet or bicuspid, really it depends on systole, right? So not in diastole. So this is aortic valve where it's open. Clearly you can see the three cusps, 1, 2, and 3. So this is a tricuspid aortic valve. To do aortic valve area planimetry, you want to make sure that you select the phase with the widest opening of the leaflets. So you go phase by phase, and then you go to the phase with the widest opening of the leaflets, and then you insert your marker at the leaflet tips. That's where you do your measurement. So you go to the leaflet tips in the coronal view or the sagittal view, and then you go to your axial view, and that's where you do your aortic valve area measurement. So here I got a aortic valve area of 1.5 centimeters squared. So one word about the use of aortic valve planimetry for TAVR. A lot of those patients, as you know, will commonly have echocardiography. And echocardiography, aortic valve area is estimated, it's not measured. So sometimes you can have some discrepancies, is what I'm trying to say, between Doppler measurements and aortic valve area planimetry. So you want to be very careful how you do your measurements here, because sometimes there can be discrepancies and you want to make sure that you're able to sort them out. So sometimes Aortic valve area, as we know, by echo can be underestimated, especially if you're underestimating the LVOT, right? Or if the Doppler is not coaxial with the LVOT, that can also result in that underestimation of gradient. So just something to keep in mind.
Geometric area is larger than effective area.
Yes, usually it's about, I think, 0.2 or 0.3 difference. So it shouldn't be too off if your Doppler measurements are accurate. Sometimes you're lucky enough you have MRI measurements too, so you can do correlations. And then Taver can also help the operator with identifying the coplanar view. That's the view that will be used to implant the Taver valve. So you can do angle measurements and also report that to the reader. So it basically just tells you what's the optimal C-arm angulation that you use during the procedure. Now, as we said, after the retrospective EKG data acquisition, we do a non-EKG helical high-pitch scan that goes all the way from the carotids all the way down to the iliacs. And so you can assess the iliofemoral arteries for size, calcification, and tortuosity. So that will help you determine if transfemoral can be the route of access. When you report the iliofemoral dimensions, you want to report the minimal diameter of these access vessels. Risk factors for vascular complications are an external sheath diameter that exceeds the minimal diameter. So if you're using a bigger sheath than your arteries, that can lead to vascular complications. Nowadays, with the technology that we have, the sheath size has decreased. So sizing based on that is less of an issue. But if you have severe calcification of the access vessels, that can lead to complications. And vessel tortuosity can sometimes be an issue. In the absence of calcification, though, iliofemoral artery tortuosity is not really a contraindication for femoral access, because once you put in that sheath, that artery will straighten out by itself. It's only when you have a lot of calcified arteries, when they're tortuous, that compliance of the artery is less, so it can lead to rupture and can have major vascular complications. So whenever we're reporting on the iliofemoral, not only do we mention the dimensions, we also mention calcification and tortuosity to kind of give the operator a sense of how feasible it is to do femoral access. So the CFA is the most common access site. So you want to look for the dimensions of the femoral artery there, look for stenosis, calcification, high bifurcation, which, as you know, can be a risk for closure. And then you always report for any aneurysms in the abdominal aorta or otherwise. Alternate sites, if femoral is not really deemed appropriate for access, you can do subclavian, carotid, or even transcaval. And so here's your iliofemoral and carotid measurements. So here's this is all from software, basically. We'll just reconstruct the entire abdominal, the entire aorta, all the way from the root down to the iliacs. So you can kind of have a sense of how much calcifications. You can have an idea if there's any focal aneurysms there. So it's a nice depiction of the aorta. Then you can look for the iliacs, whether it's on the right side or the left side. So clearly you can see here, this is a nice iliac artery, one would say, right, on the right and the left. I don't see really only just mild calcification, and the tortuosity doesn't seem to be too, nothing that should be prohibitive to access the TAVR with femoral artery. You can also, because at least our site, we also look at the carotids. So you look at the left side, the right side, the internal, external, and the common carotid. Look at the subclavian. So all these potentially can be access sites. Here's a patient that I read just a couple of weeks ago. This is their right iliac. See, there's some calcification, some non-calcified plaque there on the right side, but look at the left side. It's completely gone, right? So if you were to do femoral access on this patient, you would definitely not want to go here, right? It's completely occluded. The coronary arteries, you can also assess, but as I said, because we're not using beta blockers, where nitrates are contraindicated, sometimes it can be difficult to assess the coronary artery. So we're lucky that most of the time those patients actually have coronary angiograms, so you can always do some correlations there. But I will caution if patients, usually TAVR patients are older patients, so they can have a lot of stents, bypass, calcification. If you're uncertain about the degree of stenosis, I would not really comment on it. And instead, I would just go back to the angiogram and make correlations there. But this is a patient that I read just recently. Really not a lot of calcification. You see the left main looks good. There's a stent in the LAD. Clearly looks good, right? Like you can see it's patent. Circ, some calcification, but nothing really looks obstructive. And the RCA looks okay too. So it's important to look at every phase. Because we're doing a retrospective acquisition of the heart, so all the way from 0 to 95%, you want to look at phase by phase. So if there's a phase with motion, look at other phases, right? So sometimes the RCA looks better in systole than diastole. And you know that when we do prospective, the two phases where you have the least amount of motion are diastole and then isovolumic relaxation. So you have the entire cardiac cycle and all these phases from 5 millisecond, from 50 millisecond to 5% to pick from. So you can look at all the phases. Now, because we're scanning, again, throughout the entire cardiac cycle, we can have all these gated images from beginning systole to end diastole, so you can do end systole and end diastole, and then you can calculate an EF for your right ventricle and your left ventricle. Caution here is if you have measurements that are way off than what your eyes are seeing, or from what your TTE and your MRI show, I would be very careful about reporting a 30% EF on TAVR CT, where it's really 60% on echo. So just be very careful there. Sometimes it's just an issue with the contours, so you want to go back and make sure that the contours, just like you would do it with MRI, stacks in short axis, you want to make sure that the contour is properly aligned, so you get all the right measurements. Now again, because we're scanning, it's a big scan range. A lot of organs can be assessed, so beginning from the thyroid, the lungs, the abdomen, and the pelvis, a lot of incidental findings can be very relevant, especially as we're doing TAVR in younger patients, these lower risk patients, where incidental findings can be even more important. So we've caught tumors, we've caught so many things just with TAVR. And you'd be lucky sometimes, a lot of those patients have had concomitant CT, whether it's for chest, abdomen, pelvis, so you can also do some correlations there. Here's a patient that we read not too long ago, just very incidental. You see this PE in the right pulmonary artery. So this was CT for pre-procedural planning, where we looked at all these measurements for the annulus. It's going to help dictate the sizes, and then you look at the coronary arteries, you look at the access vessels. It's very, very relevant and very important for a successful procedure. Now, what about the use of CT for post-procedural planning? Do we do it routinely, just after TAVR? Do we just do like CT on everyone? And the answer really is no. The guidelines are very clear that you do echocardiography right just after implantation, so you can have a baseline, and then you follow them up as needed with echocardiography. And then whenever you have abnormal findings on echo, so you have higher gradients and something's clearly wrong with that valve and you can't really tell from transthoracic echo, then you can do CT as an adjunctive modality to echocardiography. Whenever you're suspecting thrombosis, infective endocarditis, or structural degeneration. So that's where the use of CT really comes in play. It's after you do echo and then you're suspecting something. So here's an example of thrombosis, patient from our lab. See if this plays here. But as you remember, the leaflet, TAVR leaflets should be very thin and pliable. You can see here that there's a lot of hypoattenuation of the leaflets called HALT, hypoattenuation leaflet thickening. And this is most commonly caused by thrombosis. Here's another way to look at them. See, all these should be very thin and pliable, but see how all this is HALT. And I will bet you if you do echo on this patient that the gradients will be high. So it's very hard to tell about the leaflets on echo because the spatial resolution isn't as good. So that's where really CT, the power of CT comes into play, where you can look at this hypoattenuation leaflet thickening. And this is one of the most severe cases you'll ever encounter. And so this patient underwent CT, showed these findings, and then recommended anticoagulation. So they were started on, I think it was warfarin. And then look at the dramatic difference here. Just after a couple of months of anticoagulation, look at the leaflets, how now they're thin and pliable. See if this video plays. See? So all this hypoattenuation leaflet thickening is, you don't see it anymore. So that's where the power of CT comes, just for those post-procedural complications. Okay. Now, sometimes you can have complications with the leaflet itself after you implant. So this is a patient who had a TAVR, a bioprosthetic valve, a transcatheter, It's actually just a TAVR valve. This was done for pre-TAVR, but this is their echo. You can see there's some regurgitation there. It's kind of more prominent here in the 3-chamber view. It's very eccentric, and the Doppler profile looks like it's kind of in the moderate to moderate severe range. So they ordered the CT for pre-TAVR workup. So here's a non-contrast CT of the TAVR valve. You can see that this is the ring where you implant the valve. You don't see really a lot of calcification if the valve leaflets itself. Really, the valve looks okay otherwise. Here's a retrospective study of the leaflets. I don't know if it's really, if it's displaying very well, but here are the 3 cusps. That's the left cusp, the right, and the non. And if it's, I don't know if it's projecting very well, but you can see that the non and the left seem to be opening well. It's only in this right leaflet here that it doesn't seem to be coming in diastole. You see, like those 2 leaflets come in diastole, whereas this leaflet doesn't really come in. Here's another view where you see the right cusp and the non. See that this leaflet is just kind of doing this up and down. So this is a flail leaflet. So this is something you can't really tell very well on echo, but this is where CT, because you have a good spatial resolution, you can tell what exactly the mechanism is for valvular regurgitation. Prosthetic valves over time can have degenerative changes and can become very calcified and thickened. So here's an example of a valve from, this was from the DeBakey journal. See all this calcification along the leaflet, along the aortic valve TAVR leaflet. So this is severe degenerative thickening of the leaflets. TAVR has also been approved, as you know, for valve-in-valve procedures. And so in that case, the TAVR, CT for TAVR is very important to look for, what's the feasibility of putting in a valve in that TAVR valve or even TAVR valve. So that's the importance of CT for guiding procedural access, procedural feasibility. So in that case, you want to do what's called a virtual ring to coronary distance. So you do, this is from the SCCT guidelines, I just pulled them up. So essentially you want to do just the way you do it with TAVR, with native valves. You want to look for the lowest insertion point of the TAVR leaflet. So this is the lower insertion point. So you do a double oblique view. Same thing, you identify the lowest insertion point of the right, and then the non, and then the left, and you get to this plane where it has all 3, the lowest insertion point of all 3 leaflets. And then you put your center here, perpendicular to it, and then you go up, you move up until you identify these valve posts. Remember, with TAVR valves, you have these posts of the valve, it's like the tip. You draw a virtual ring that's bisects through all 3 posts, and then you draw a distance from the outer edge of that virtual ring to the left coronary ostium, and you measure what's called a virtual ring VTC distance to left coronary ostium, and then you do the same thing for the right coronary ostium here. And then usually it's 4 to 6 millimeter. If it's more than 4 to 6 millimeters, then it carries a low risk of coronary ostial obstruction when you put in that Taver valve in the bioprosthetic valve. So here's another way of looking at it. So you assess the valve type. So there's two types of Taver valves. There's the stented ones and the stentless ones. If it's stentless, then you're good to go. You just do your coronary heights as you would with a native valve, and then you should be okay to proceed with that. If it's a stented valve, then you need to report this virtual ring to coronary ostia distance. Now, if the ostium of the valve is above the plane of the post, so see this example here, this is the left main ostium, it's above the, if it's above the level of the stent post, then there's no risk of obstruction. If the ostium here is below the level of the stent post, then you need to do these measurements that we discussed in the previous slide. So this is actually that flail that I just showed you with the Taver. Coincidentally, actually has a lot of pannus here in next to the non-coronary ostium. So pannus versus thrombus usually is based on your Hounsfield units. For thrombus, it's around 60 to 70, maybe up to 80, but then for your pannus, it's in the 100 to 150. So this patient had pannus in the non-coronary, but then you see that the left coronary ostium is way above the level of the stent post. So in this patient, is a very low risk of coronary obstruction, and you just do your regular measurements for your coronary heights and whatnot. And that's all I have for you. Happy to take any questions or.
Since we don't give beta blockers, or my question is regarding beta blockers, how high of a heart rate are you willing to accept before you really need the beta?
I think we're a little bit permissive with the heart rate. As long as, especially with our scanner, we use a Siemens 4, so it has a very high temporal resolution of 60 milliseconds. So because of that, we're able to tolerate a little bit higher heart rate. But yeah, I don't know if there's like a threshold above which we shouldn't be doing the scan. But because we have a good spatial temporal resolution, we're going to be able to acquire those images with the least amount of motion. The whole idea is the motion, not in the coronaries, it's in the annulus itself, because that's where the measurements are key. Yeah, John.
Do you have any protocol to look at the membranous septum on these scans? And is there any way to kind of quantify the amount of calcium on each leaflet?
So for your first question, you mean like the ventricular septum?
Yeah, the membranous septum. There's some literature here and there about measuring the length of the membranous septum.
Okay. Yeah, I mean, I'm not aware of that literature, to be honest with you, but yes, I mean, when we do these retrospective gated measurements, remember a septum is somewhere here, so we can do all sorts of reconstructions to get to that septum. And so we'll commonly, we can look for, if there's a VSD, you'll see left to right shunt with contrast. We've commonly diagnosed ASDs and PFOs based on that left to right shunt of contrast. But I'm not aware of any specific measurements that we commonly do just for that septum. Regarding aortic valve calcification, so it's all based on the Agatston scoring technique. So it's based on the density of the calcification and the area of the calcification. And so we just go back to that slide. And so the same way we just identify. The best is to do a double oblique, so you can know exactly where that calcification is, because you want to make sure you exclude any aortic root, mitral annular calcification, or coronary ostial calcification from your aortic valve measurements. And then all what you do is you do a ROI. You can either do it with, it can either be done manual, or if you click a single click, it will identify all that calcification. But be careful when you do single click. it can incorporate some non-aortic valve measurements. So I will do manual and just go up, down, up, down, up, down, until I make sure I encircle all the aortic valve calcium, and then the score will give you an Agatston score, and you just report it. Yes, sir.
Yeah, thanks for this presentation. My question is about on the same lines of the valve also. One of the slides you said 1,600 and 30,000.
Yes.
Male versus female. But I know sometimes in clinic when we have like whether ASC severe or not, we use 1,200 for women and 2,000 for men.
Yes.
I'm just trying to reconcile both of them.
So these are numbers I picked from the guidelines. I think those numbers are very, very specific. So if you're more than 3,000 for men or 1,600 for women, then the likelihood of severe AS is very, very high. If you pick a lower threshold, you're a bit more sensitive, but maybe less specific. And again, nothing is done in isolation. It's you have your echo, you have your TAVR measurements, you have your aortic valve calcification. It's all taken in context. But this is just one piece of the puzzle.
I mean, you gotta be very careful also. The relation of aortic stenosis severity to calcification is not a very tight one. Meaning that you can have severe aortic stenosis without very high calcification. Particularly in women, you may see that. So, and remember you're dealing with calcific aortic stenosis of the older individual. If you have a bicuspid valve, conceivably calcification may not be as impressive. If you have a rheumatic valve, it may not be as impressive. And to me, the calcification is probably the least I would rely on for somebody to define whether you have aortic stenosis. You would do it only when you're stuck. I'm stuck meaning I'm stuck with a low flow situation. Low flow influences severity of the valve, right? And I cannot augment flow by a dobutamine or artery stimulation. So I'm stuck in a situation where I need help. And this is actually, if you look at how the guidelines are set. You do physiological testing, baseline, dobutamine stimulation, and if I'm still unable to improve output, I would use that and put it together, right? So, but you need to take a look at the original data of severity of aortic stenosis to calcification. Very wide plot.
How accurate is the valve area measured anatomically in the CT, and how well does that area correlate with actual severe aortic stenosis?
If done properly, it's very accurate, within 0.2, 0.3 centimeters square difference, not much. But again, it has to do with how you're doing your measurements. So leaflet tips, and then you pick the phase with the widest leaflet opening. You can't select a phase where the valve is still not as, the excursion of the leaflets hasn't yet maximally occurred. So with that, you can overestimate stenosis severity by underestimating the area. So you go phase by phase, largest opening, and then the leaflet tips, and that's where you do your measurements. And if done properly, it will correlate very, very well with echo.
It's an irregular funnel. It is not in the plane. So it's very irregular border, and there's really no single plane that will tell you what the actual area is. The usual issue is conceivably an overestimation of the area, because if you're in the funnel, you gotta be very careful about it. And also the heart descends in systole, right? So if you're looking at an echocardiogram in short axis, you have no idea where you are. Same thing here, which is much better in CT because you know where you are, and you want to make sure you're close to the tip of this funnel, right? But none of them are, it is not a planar structure. It's like this, and I want to have a feel for that. And remember, nothing in life, except very few things, are dichotomous, right? So don't get stuck on the valve area of 0.95 versus whatever. Just use the whole thing. Use hemodynamics, gradient, valve area. Look at the actual data, because all of these, have some errors, and they have to click together.
Great point. All right, thank you.